Okay, thanks everyone so much for joining us today. Today we're going to cover a couple of different things. If you want to go to the next slide, Jake. So we're going to start first with talking about the dashboard. So you all should have received an email from Friday from the Michigan Data Collaborative about a new release. So this is the second release of the dashboards, and we're going to go through those extensively. I'm going to hand it off to Jake, our quality improvement specialist, who's worked really closely with MDC on making these updates, and he's going to talk about the new features with you. We'll show a demo of the dashboards and go through and just give you a few other updates related to the data. Then we're going to circle back and talk about the level 2 VBR that we introduced last month. We've made a couple of changes that will hopefully make it easier on you and your practices, and we'll go through those as well. And then we just have a few reminders, including about the QI logs that we've discussed a little bit in the past, and we're on your monthly calendar that we distributed, and also talk about the next calls. So to get started, I'm going to go ahead and hand it over to Jake, who's going to walk you through the new dashboard information.
Great, thanks, Jackie. Good morning, everyone. All right, so we do have updated data on the dashboard. So the clinical data now is through October 31st of 2022, and the claims is through November 30th of 2022. So some added features of the dashboard, which I will show you in the actual dashboard environment in a moment, include the addition of statin medications, as well as the remainder of diabetes medications, for example, sulfonylureas, DPP-4 inhibitors, and so on. We also added blood pressure, last blood pressure. So actually the last two blood pressures that we would have received for the patients, and as well as whether or not that patient has had a retinopathy screen in the date of when that last retinopathy screen occurred. We also added a second tab, again, which I'll show you in a moment, titled the renal patient list, which includes some more kidney-focused metrics that are very relevant for patients with type 2 diabetes, specifically looking at chronic kidney disease diagnoses and whether that patient is under the care of a nephrologist. And we also added whether or not that patient has a pharmacy carve-out, which is going to be very useful as we start looking at whether or not patients could receive a prescription for a CGM, and we will show you that. All right, I'm going to switch over my screen sharing here. All right, so we can now, hopefully everybody can see the dashboard. So this is a demo environment of the dashboard. And so the big thing here is that you'll notice there's now a button on the bottom here that says more filters. And so this is going to be where you'll find a lot of the new filters that we've added. And so on this main page here, you have everything that you've seen before that you used to have, including diagnosis of type 2, the age, A1C, BMI, weight change, and then all of the meds that we already had. And so we can see our patient list on the right here. So if I click on more filters, we actually see, after it loads, the new filters that we've added. So you can see that we actually have systolic and diastolic blood pressures here. You can filter based on whether or not a patient has those and max and min values, as well as statin status, which is the same dropdown as the other medications that we have, including active, inactive. Again, our definition of active for the purpose of the dashboard is a fill in the claims in the last 6 months. We also have sulfonylurea as a standalone filter class, as well as other diabetes medication status being any other medication, any other diabetes medication, excuse me. All right, so I'm going to go ahead and hit less filters here. And then on the patient dashboard side here, we have these tooltips, this magnifying glass. And so if we hover over one of those, we get a quick glance at what the patient has. And you can see in big orange text on the bottom there, it says this patient does not have pharmacy coverage with Blue Cross Blue Shield of Michigan. So this is a good way to tell from the dashboard side whether or not a patient has a pharmacy carve out without even having to click on the patient. If I hover over here, we do see that this patient, I'm going to go ahead and click into this. Again, this is all demo patients. This is not actual PHI. We can see a sample of what it looks like here. So you can see that we have our meds on the right here like we have before. We also have this blood pressure category here, which is new. And so the one thing I wanted to mention about blood pressure, we are limited in the way that blood pressure is reported through PPQC data. And so this is an aggregate. So occasionally we have duplicate records, and we don't always have the ability to match up systolic to diastolic if there are multiple recordings within one day. So if a patient has like 2 or 3 blood pressures taken at one visit, we can't necessarily tell which diastolic goes with which systolic. That's kind of a niche problem because is not terribly often where there's multiple blood pressures, but when that is the case, we do take the lowest value from both. You can also see here the pharmacy claims data available for November 2021. That's how we are noting whether or not this patient has the carve out. So you can see that we do have pharmacy data available for this patient, which is clearly evident based on the fact that we're showing meds here. All right, I'm going to go back and find another patient. Hopefully one that I can easily find that has a couple of other features. I'm going to let's see how we look here. So you can see that this patient right here has this retinopathy screen. So this pops up because they have had a retinopathy screen on 5/18/2021. So this will actually be static. This is a remnant of the demo environment, but this will stay up, and retinopathy screen will be displayed here even if a patient does not have a record of one, and it will say none found on this here. There will also be additional things that could pop up here, such as the chronic kidney disease diagnosis. So if they have that, that'll pop up as a box here, and then it'll say last assessed, and it'll have a date for that, as well as whether or not they're under the care of a nephrologist. All right, so those are our additions on the patient side of the dashboard. So if I go back to patient list, we'll see that there's actually an additional patient list here. This is what I mentioned about the renal patient side. So if we click on this, it's almost identical. It'll contain many of the same filters, but it'll have a few less and a few different ones. So we can see here now that we have these two main criteria that we can filter by. So chronic kidney disease, so we can filter by a yes or no for a diagnosis prevalent in the claims. Also search by nephrologist care, and this is simply whether or not they have had any claim for being seen by a nephrologist in their medical record, and so we can search by that too, which is fairly useful if we do want to know whether or not any of our patients are being seen by nephrologists. If they do have a diagnosis of chronic kidney disease, you could also search by a no to understand which of your patients who do have CKD are not under care of a nephrologist. For more filters, there's really not much else here. We wanted to keep this page a little simpler. And so that's everything you need is actually right on this left-hand panel. You can see also, so that if we do hover over this, we can see we do have kidney disease and nephrologist. So any of these patients should have CKD diagnosis. I'm just going to click on any one of these patients. And you can see the CKD pop up here now. And you can say diagnosed on 11/30/2021. All right, that is a high-level overview of the updates of the dashboard. I do want to take a moment and ask if there are any questions or clarifying questions that I may be able to answer for anybody. I see a couple of comments in the chat. Let me see if they're okay. That looks like that. That was taken care of. All right, hearing none, I'm going to switch back to Jackie, or back to the presentation, actually, sorry. New share. Okay, and so what I wanted to do also is provide a couple of use cases where kind of give it some relevance behind the filters and some things that practices and POs could be using these for currently. So in the future, in future updates, we do plan to have additional tabs at the top there that will be pre-built filters that a provider could click on with a title, just to have very easy, ready access to certain categories and lists of patients. But so for the time being, here are some potential filter combinations that a provider could use. So for example, if the goal is to identify cases of high therapeutic inertia, you could search for patients that are only on metformin with an A1C of at least 7.0 and are not on any secondary medications. And so that would be a good patient that may be able to be considered for additional therapeutic intervention. If your goal is to identify patients who may be a good candidate to offer a CGM to, and you want to make sure that they have a very, as easy as possible to get it covered by a CGM, obviously it's a very nuanced process. But you could search for patients with a type 2 diagnosis on insulin, have an A1C of greater than 7, have RX coverage. No, that's not currently a filter, but again, you can see that by hovering over the magnifying glass, even without clicking on the patient, as well as currently on a CGM. So again, not a filter. It will be in future releases, but you can see that by hovering over the magnifying glass as well as on the patient profile. A third possible use case would be to identify patients for whom a low carbohydrate diet may be offered. So again, an A1C of 7.0 or something similar. This is clinical judgment, just as an example. This is provided with a BMI over a certain criteria who are not currently on an SGLT2 inhibitor. Obviously, we know that there are some contraindications, especially with very low carbohydrate diets in SGLT2 inhibitors for euglycemic ketoacidosis. And so other possibilities here, if we want to identify patients who may be a good candidate for use of a GLP or an SGLT2 and getting them off of that insulin, we could search for patients on insulin, not on either of the GLP or SGLT2s that we're interested in. And then again, some arbitrary A1C and BMI categories for patients that may not be well managed. A couple more here, identifying patients for SGLT2s. Again, we know that SGLT2s are very beneficial in patients with CKD, so we could actually filter for patients on with a diagnosis of CKD and are not currently on an SGLT2 inhibitor and have, again, an A1C that would be conducive to adding a second line of treatment. A goal, and our final goal here could be to identify patients who do not currently have a diagnosis of type 2. Again, our dashboard pulls in patients based on 3 different criteria. One, having a diagnosis of type 2. Number 2 is having an A1C of greater than or equal to 6.5, regardless of diagnosis. And a third being on any diabetes medications, regardless of diagnosis of type 2, with the caveat that anybody with a diagnosis of type 1 is excluded. So that is important. So if you wanted to see, oh, how many of my patients do not currently have a documented type 2 diabetes diagnosis, but have an A1C of a certain criteria. This says 7, but you could set it to 6.5 as the ADA clinical guideline to get an idea of how many patients, if any, that you have that may want to be worked up for type 2 diabetes. So these are just some examples of some possible use cases for these filters. Obviously, there's a lot of clinical judgment that goes into these, but we wanted to provide some relevance to that. All right, Jackie, I will turn it back over to you for this, I believe.
Okay, sounds good. So we just wanted to let you know about the most, I can also take over sharing if you'd like, Jake, if that would be easier. Sure. Wanted to let you know that with this new version of the dashboard, we are still waiting to get specialist attribution completed. MDC is figuring out the best way to go about that, and they aren't completely ready yet, but we're hoping for these next updates that we'll maybe have it. And then any primary care practices that were added in November as opposed to the August start date, those are not yet added either, or they'll be added by the May refresh at the latest, but we're hoping to get them added even before that. So we're hoping to have that to you. Also, before we move on, I did see there was one question in the chat. It was CKD can be diagnosed and then resolved. Do you have a way to resolve this in the list? So for example, a CKD is diagnosed inpatient or post-hospital event and then returns to no CKD. Do you happen to know, or do we need to circle back with MDC?
So we'll circle back with MDC. Currently, it's being pulled from a diagnosis in the claims. And so as long as it's showing up as a historical value, it would show as a patient having a diagnosis of that. It does have the date of the diagnosis listed, but that's a good point and a point well taken that we should have a way to understand whether or not that is resolved or if it's a chronic case. So we'll circle back with MDC on that. Thank you for that comment.
Thanks. Also, Jake, you can see my screen, right? Figured I'd check before moving on. Okay, thank you for going over that demo. This point right here is just so that you have this in a slide regarding the RX coverage. And the reason we really wanted to highlight this is because when we sent out like our CGM coverage guidelines, we definitely had some providers reaching out after that saying, hey, this patient, they have Blue Cross Blue Shield, but they were denied what's going on. If I sent it to the pharmacy, this should be going through. So This will be partnered with the tool that we already sent out, hopefully helpful in determining before those prescriptions are sent, like this patient looks like they have Blue Cross Blue Shield, but do they have it for the pharmacy side as well? So again, Jake went over this, but just wanted to have this slide here for you too, as we think this will be useful to making sure that some of these CGM prescriptions don't get denied, so that you have a full picture of what their insurance really is if they have that Blue Cross pharmacy coverage as well. And then just wanted to give some general updates related to what you can expect with the dashboards for the remainder of this year. So like always, we'll share these slides so you can refer back to them, and we'll also build these into our upcoming calendar invites or our upcoming calendar updates. As a reminder, we sent out that overall calendar, but each month we'll send you like an update of, you know, new information that we have, such as something like this, like the new release schedule or other events that have been added. So you'll be able to see these in future versions, but we're now updating the data every 6 weeks. We're working on decreasing the data lag still. We've made some good progress with this most recent update and are continuing to work with MDC to figure out how we can reduce that even more as we go forward. So this right now is what we currently have scheduled through the remainder of this year. And it's either a refresh or it is a refresh and enhancements, which will be new features like the ones that we just went over now. So we can expect that to be the case for the remainder of this year. And in June, so as you can see on this last slide, the next kind of update and enhancement is in June. Prior to that, we'll refresh the data. So instead of November and October through it, we'll have it through the end of January. And then for that next update in June, we'll have this major update of the summary statistics, which I think will be really helpful. And we've been working closely with MDC on what these categories will look like. So you'll be able to look at practice averages compared to the collaborative, compared to the PO, compared to region. So you can see what that looks like for certain elements in the dashboard, such as HbA1c. And then we are also hoping to add a filter where you can tell if a patient has a CGM prescription or not just by searching it. So right now, it's covered in the dashboard on their patient-specific page if they had a CGM prescription, but we'll add a filter so that you can easily identify those that do and don't have that CGM prescription. And also too, just wanted to give an update on all the different data sources that we have kind of in play here so that you know where these are. This is in comparison, you know, to the all payer, all patient dashboard that we're working on building and all these different sources that we're trying to bring into it. So to give some updates on where we are with each of these. So the main one is all payer PPQC data. So that relates back to the letter that we asked you to sign in January, giving permission to share all payer PPQC as CCDA data. They actually have begun sending it. MyHIN has. We have a little bit to figure out still technically with that, and we may be reaching out to POs that, you know, agreed to send it, but MyHIN hasn't been able to for some reason. So there's a few technical issues we're still working through. They're figuring out sending it, and then once they do, it'll take about 6 months to build this data into the dashboard. So hoping, you know, by the November release or the one in December that we've been able to build in that all payer PPQC data. We're also working on BCN PPQC data, which is actually part of this all payer piece, and claims data. So BCN claims are going to be added to the dashboard as well, hoping to have that by the end of the year too. So expanding those data sources in 2022 to be both the all payer PPQC and the BCN claims data. For the all payer CCDA data, we still have some legal and technical requirements that we're working to build out. So for example, we need to build an environment to receive the CCDA data from MyHIN before proceeding. So that's going to be a little bit longer and not have as clear of a date that it's absolutely going to be in the dashboard by, like we do for the BCN claims and the all payer PPQC. We're also working on Medicaid claims. MDHHS is open to sharing these for the purposes of the collaborative, and we're just working through some of the legal pieces of that. So there's a data sharing agreement that they sent us that our legal is reviewing, and once that's signed off, it'll go back to MDHHS. So again, with this one, we don't have a specific timeline, but it is in progress, and MDHHS is on board for this. And then we also are thinking about adding and how we're going to approach adding additional payer claims. So we have like the cost estimates from MDC on what it will take to bring these on, and then working with the payers to do so. We're hoping to start with Priority Health, just understanding that on the west side of the state, they're a very large presence, and it would be very helpful to have them added to the dashboard. So we're working through what that will look like and what the cost of that will be. So that's kind of where we are with these different data sources so that everyone's up to date. It looks like there's one question in the chat. So practices that have changed affiliation, when will their data drop off our dashboard? So I will update MDC for this next release that's going to be in May with the most current practices that are participating. So they'll be able to do that then, and we'll make sure that any that have changed affiliation are removed. I think that's the end of the data section. Let me see. Yes. So we'll pause really quick to take any last questions on the dashboards or the data and any updates we're making to these for the remainder of the year. Okay, sounds like there aren't any. Definitely feel free to follow up with us afterwards if you do have any, but hopefully these new updates and the reduction in the data lag on the dashboards helps them, you know, get a little bit more useful to you and your practices. And through the examples that Jake gave, there's some clear applications to clinical care that hopefully we can use these dashboards for, and they'll start providing some value to your practices and to you as the PO. So moving on, we wanted to talk about the learning community. So last month we introduced the requirements for this in detail. We wanted to have a discussion with you all about the components and some changes that we may make to it. So we want to make sure that this works for you. And so please speak up, please share your opinion about anything. We want to know that what we're doing is going to work for you and be feasible. So to go over, this is what we introduced last month. So we had level 1 requirements and level 2 requirements, and we asked that everyone earning VBR completed one of the options from level 1 and one of the options from level 2. So upon reviewing that and after hearing from a PO about how it would be for them to complete this, we decided to make this a little bit easier and require less from this level 2 piece. So instead of this level 1 and level 2, we've decided to break this into a physician level, a practice level, and a PO level. And the ultimate goal of this split is to remove more intensive per physician requirement and scale it back a bit where the practice or the PO can contribute, and that's going to count for everyone in the practice. Similar to how the clinical champion completing the training counted for everyone completing the training, we pulled back what we're asking for level 2, made it simpler on the individual physician, and either changed it to practice or PO. And let me go into additional details of what that will mean. So we're keeping this first section, the complete same. We changed it from level 1 to physician level so that you understand that the requirement is for each physician to complete one of these. So these are still the same. We have testing a learning community tool. We have the links there for them, and we also have the review documentation ready too, so they can do this at any time. So they can try, for example, when prescribing one of the GLP-1s using our tool that talks about coverage, and then following doing that, give this short, like kind of 1-minute review of the tool and how they used it and if it was helpful, and if not, what should be different, and then they're covered for that. Alternately, they have these different options of completing a learning pathway or attending a live community learning event that'll be hosted later in the year, kind of targeting July for the first one of those, and we'll have another one before the VBR year is over. We wanted to mention that as far as the learning pathways, we've now included our 3 trainings as a learning pathway option for all VBR earning physicians who, aren't clinical champions, who've already completed them. So as long as they take one of these and they can determine which one makes the most sense based on their comfort level, their familiarity, maybe they've prescribed CGM and prescribed these medications a lot, but haven't done much with low carb diet. So that physician may choose to take the low carb diet course, for example. We're not going to say which ones anyone should take, but we also did provide an optional training needs assessment for you as the PO to use. So if you want to use that with the practices to determine which one may make sense, but just wanted to let you know that those are all going to count towards that. So the physicians can meet that requirement by watching just one of the training courses that we have live too, and that counts as like the learning pathway event. So as we said, this part's staying the same. They do one of these three, each physician that earns VBR. This is where we're suggesting some changes. So previously, we had these 4 options that were divided up into level 2, and each physician was going to have to do one of these as well. So in order to reduce the burden on the individual physician that's earning VBR, we pulled it back and made it either 1 per practice or 1 per PO. So it's going to be administratively a little bit different to track than what we'd originally proposed, but it will be less work for your individual physicians at each practice. So now, instead of each physician having to get feedback from a patient on a tool or refer a patient to the patient stories, this just has to happen once per practice. The care manager can be the one to set it up. The RN can be the one to set it up, wherever it makes the most sense to introduce the patient to this tool and have them complete it, or to identify a patient that would be a good fit for our patient stories. Once this is done at each practice, it's complete for every physician in this practice. So like I said, kind of similar to the trainings. Once it's done for the clinical champion, everyone has that requirement met. That is how it's going to be for this as well. So once one patient learning community tool is evaluated, that practice has that entire requirement met. And for the patient stories component, we have really, it's just referring a patient who would be willing to do it. So it's not that they follow through with it. It's just really completing the patient referral form. And that could be any patient who's had, a good experience with any of these interventions, who may want to provide a quote or share a story. We have multiple different ways that they can participate in this. That's not just being on a video like you saw like at our kickoff meeting with the short patient stories, but there will be other options for their involvement. And for the practices, it's just getting one patient who may be willing to talk about their experience with these, and then we would work with them to figure out what works best for them. Then at the PO level, again, this was previously part of that level 2. What you would do now is for each PO. So once your PO is done this, and it can be with any provider at any of your practices that do this, it's complete for everyone within that practice. So, or within that PO, sorry. So that can be either participating in an interview for a blog, or a video with our coordinating center team, or sharing your practice's expertise at a live event as a panelist. So what that would take is like completing that form. And again, once you have one person at your PO who's either participated as a panelist or done this blog thing, you're done there as well. So remove this, pulled it back from like the individual VBR earning physician to a little bit less of a burden on them to do. So this is kind of the overall picture. So now here is the same thing we talked about before, where each physician has to complete one. Now we have practice level and PO level instead of requiring individual completion here. So we will track this for you extensively on our VBR tracking, so you never have to wonder like what's been done. We're going to split it out. So the level 1, the physician level is 1, the practice level is 1, and the PO level is 1. So you'll be able to see what that looks like. So for example, once you submit a person who will participate in this like blog or video, every single physician that's earning VBR is going to be met for the PO level. So hopefully that makes sense and is clear to everyone. Let me talk through this a little bit more about what this might look like. We tried to estimate the average time and what this may look like to complete these different activities. And this is focusing specifically on the PO level requirements for you around what this last part would look like on referring someone. So we are going to write up like a template for you for both the blog posts and participating as a panelist and what that will look like. You would email that to whoever you want to share that with in your practices. So we're not requiring that it's a physician who participate in the blog or participate as a panelist. It can be any person within those practices, and it's going to count for these requirements. So then the providers in your practice would agree that they're interested either via you or, in any of these other events as well. And we'll communicate back with you as that goes on. And then we will work with the physician and the others at the practice, whoever is doing this, around like what this looks like. So for example, the PO time commitment on this, around 2 hours. I honestly think it will be much less than that. It's really just sending out these emails and identifying the people who might be a good fit to do this in the practice. And then for the provider commitment, depending on what they decide to do, if they want to do a blog, there would be a short call with the coordinating center. we would write this blog and then we would send it to them to review and sign off. So really it would be participating in this like video interview with us and then reviewing what we've written. And then to participate as a panelist, the commitment would be around 30 minutes to 2 hours, really just participating in that meeting and any kind of prep time that they would need to do prior to that. Here, this is kind of written out a little bit more specifically just to walk you through exactly what it would look like. So you would identify a physician or another person in your practice who would be a good fit for an activity, either a blog or a panel. They would contact that person, ask them to participate. This says physician, but like I said, it could be anyone within the practice. That would be a good fit for this. We provide you that template. The PO sends the interest form to them. Then that's where your responsibility ends. We'd reach out to the person, have a 15-minute phone call with them about like this blog, for example, and then would either be in this interview or this panel. We would handle all the writing, video editing, plan it, and then they would have the chance to edit as would you. So this is sort of what that would look like for the blog piece of this or like the panel. That said, I know it was a change in what we talked about, and it's a little bit more complicated than the initial version, but we thought it was worth it for the trade-off and what we're asking your physicians who are earning VBR to be doing. What questions does everyone have? And does this seem like feasible and an appropriate amount of work? And I invite anyone to speak up, share their thoughts about this around the changes that we've suggested. Okay, so sounds like not too many thoughts on it. So this is what we'll plan on doing going forward instead of that per physician requirement. So what we're going to do is update all of our documentation. You know, we have it updated on this slide, but we'll make it a little bit more clear. And we're going to have your VBR requirements on your tracking thing updated, ideally by the end of this week. So you'll be able to see this a little bit more clearly. And like everything else, we'll work with you to make sure that this is accurately tracked, that you understand it, that you understand where they haven't been met and have the opportunity to follow up. So we're not just going to put this out there and not make sure that you're supported in it. We're going to make sure you know everything that you need. One of the questions was, is the deadline still September? Yes, it is, because that's the VBR year and Blue Cross needs these requirements to be completed within the VBR year that exists. So yes, the deadline will still be September, but with all of these, they can all be completed now at some extent. Really, the panel, like I said, will be hosting those more in July. So that's the one thing that they can't, but a blog, we could start doing that literally immediately and have that PO level requirement completed by the end of this month, and it's done for everyone. Same with like the learning community tools and the patient stories. These can happen at any time and can go underway now. So still have about 6 months to get all these requirements complete. Okay, and like I said, we'll continue to communicate with this. If there's anything confusing about it once you're looking at it, or we'll make sure to clarify anything. We'll update you multiple times throughout the year, in addition to the live tracking on if there are any that are still needing to be met. So hopefully this reduces that per physician ask a little bit and helps makes this a little easier on your participating practices. Another question about when you need to look at it. So we can, I can send out the slides right after this and the recording as well. This meeting, again, someone asked when the repeat of it is. We also host this on the 23rd as well at 2 p.m. So that's when the next one of these will be if you wanted to attend. It'll be the same content, but if you're welcome to join. We'll send these out right afterwards to everybody. So then just a couple of reminders and things to know. So we mentioned when introducing the learning community that these newsletters will be released beginning in April, and that will include things like updates to the calendar, etc. So we will send you the newsletter, and then we aren't at this point going to send it directly to your clinical champions. Again, we completely understand that you want to introduce things and kind of own the relationship with these POs, but we will have like a newsletter sign up form. So if you want to not always be responsible for forwarding these onto your clinical champions, you could say, you know, we're going to forward this time, but here's where you sign up for it, sign up in the future. So you can handle this however you want. We'll always send it to you first, but you can also share with them to sign up directly with us as well if you want to make sure that they get it each time and not be responsible for forwarding it. So the last thing I wanted to touch on was the QI log. So this is a PO level requirement that was in the participation agreement, that was in the informational sessions, like from kind of the start of this program, that we're asking the POs to submit a QI log. This is exactly kind of the text in the participation agreement. We included this on the calendar that it would be distributed in March and then due back to us in May. So 2 months, pretty much exactly from when we get it to you tomorrow to when it's due. And I just wanted to cover a little bit more of what this would look like prior to us sending it out tomorrow. So we are going to send it to the PO admin leads and the primary contacts. It'll be an online link that you'll complete, but you'll have the ability to save progress and come back to it. So you don't have to log in, fill it all out at once and submit it. It'll stay the same, and until you submit at the very end, you'll be able to join. So the format of it, it's mostly qualitative questions. There's like 4 general PO level questions about the support that you're providing to your practices and what you're planning to do, what you have done. And then there's 9 questions for each of the 3 main MCDGD focuses: low carb diet, CGM, and medications, where we're asking you to kind of summarize generally across your practices and what's been going on, how you've been changing workflows if needed. And they are all the exact same questions across the 3. We've just split them into sections: low carb diet, CGM, and medications. The estimated time to complete, once you kind of have a oversight of what the answers are, so this would be like writing answers and filling out the QI log versus like getting the background information needed to answer these, because I think that will vary across PO depending on how involved you are with the practices and how much you know they're doing. You may not have to ask them anything, or you may have to go to each of them and ask them a little bit more about what's being done. So that's why it's only estimated as filling that out. But I think it will take approximately an hour to go through and submit this, and you'll be able to look at it tomorrow. You'll have the 2 months to do it. We also have an optional tool that we created for those who do need to reach out to their practices and determine what they've been doing for each of these. So we wrote just a very high level the different initiatives here, as well as like an other category to talk about any other changes in their type 2 diabetes care that they may need to make. And then really it's just 5 across the top. So prior to MCDGD, how did your practice prescribe this? What was your approach? I wrote an example here just so you could kind of see, and hopefully it'll be helpful to your practices. Following the training, have you changed any workflows? What roles are different office members taking on in relation to the workflow changes? Have these been helpful, and what else needs to occur? So pretty high level, just the simplest like look at what's been going on and what changes have been made. This isn't going to be due back to us in any sense from any of your practices, but if it is something that you would find helpful for your own purposes and trying to fill out the QI log, you are more than welcome to use it. And when we send you the online link, we'll share you this template in like a Word document as well, that if you want to use, you can. So as a really high level example process for filling out this QI log. So tomorrow, like I said, we're going to send this to the PO admin leads and the primary contacts. So first step would just be reviewing the templates to see what you're responsible to answer and to see if you think the workflow change tracking log that I just showed is helpful and that you want to distribute it. If you do, you may determine that it would be useful. You decide to distribute it for participating practices. You send that out, give your practices a month to complete it, for example. So you'd be getting all those back on April 15th with the month to complete the QI log. If you wanted, you could go in and complete the PO level questions. Like I said, progress gets saved, so you have those completed. Then once you get those back from your practices, you may use those to inform like the other responses on it, and then you complete it and submit it by 5 5:15. So like I said, this is just a high level example of what that process would look like. You can absolutely approach this however is most useful to you, but wanted to give that overview. And we'll likely do these QI logs on a yearly basis. I think we will change them, and they'll develop over time as we focus on different things and as we're at different places in the process of implementing these initiatives. So I wouldn't expect it to look the same next year necessarily, but this is what our initial one will be. And hopefully this is helpful to you to kind of understand how to approach it. So that is all we had for you today. I wanted to let you know that the next PO monthly calls that we'll have will be in May. We're going to cancel the ones in April to focus on the regional meetings. And then when we come back in May, we'll have extensive updates once we've completed all of the regional meetings and have some kind of key takeaways with you that we'll share with you on these May ones. And then we'll also cancel the June monthly call since our collaborative wide meeting will be June 24th. So shortly after this wraps up, I'm going to send the cancellations for the April and June PO meetings, and I'll send out these slides as well. We won't have the recording up just yet, but we'll try to get it to you as soon as possible. It'll just take like an hour to download and be ready. So we will send those out shortly. Got a question in the chat. How's the conversation with other payers going regarding the medication cost requirements for members? So the main challenge that we've had regarding the medication costs, at least as it's been brought up to us, is at least from a deductible sense, payers have been telling us, we don't set our deductibles. The employers, the customer groups, they set the deductibles and they don't have a lot of influence there. And same with copays. So each individual employer or customer also has a lot of control over what their copay is as well. That's why when it's reported in their overviews that they give, it's always by tier, and then it's really the individual employers determining what those tiers would be. I think what would be most helpful would be to get in some of their employers and get in front of some of them and talk with them about how to make these more affordable and why these high deductibles and high copays, particular in regards to these medications, are problematic. Someone did point out in the chat that Priority Health is making some of the meds more expensive for members and are moving some from a tier 2 to a tier 5 coverage. So I hadn't heard this. Last we talked with Priority, we were like, oh, okay, their coverage on these things is pretty good. But thanks for bringing this to my attention, Christina. We'll take a look and make sure that our documents get updated around coverage so that it's clear as possible on ours what is and what isn't going to be approved at a lower cost. And we'll also are hoping to have another conversation with them soon regarding the claims data for the dashboard. So we'll make sure to cover the medications portion as well and try to understand this a bit better too. Any other questions? Okay, well, thanks everyone for your time this morning. I hope it was helpful to see the dashboard, and hopefully these changes to the learning community make this a little bit easier on you. We will get you these slides ASAP, and we'll work on updating our materials around the learning community and get that to you soon as well. And please reach out once you've had some time to consider and think through all of this if you do have any questions, and we will make sure to get back to you ASAP. Great. Thanks everyone for your time today. We really appreciate it. I'll stay on in case anyone does have questions. Okay. Any questions at all? Okay, in that case, I'll go ahead and end the meeting. Thanks everyone for joining, and we'll talk to you soon.